Great. All right. I'm happy to be able to present the introduction for Dr. Rachel Safian. She's a medical oncologist at the Fred Hutchinson Cancer Center, specializing in the treatment of gastrointestinal malignancies with an emphasis on pancreatic and colorectal cancers. She is a clinical and translational researcher focusing on developing clinical trials for patients with pancreatic, colorectal, and other gastrointestinal cancers to advance novel therapeutic agents and identifying response biomarkers. She's also a medical educator and has received several honors throughout her training, including the ASCO Conquer Cancer Foundation Young Investigator Award. So welcome. We are thrilled to invite you to Nebraska for the first time.
Thank you. Well, thank you for inviting me. It's really an honor to be here to discuss the 2024 ASCO updates in the treatment of GI cancers. So I have the following disclosures. All right, so I'm going to give you a whirlwind tour over 8 trials, 4 disease groups. We're going to cover the ESOPEC trial and esophageal and GE junction adenocarcinoma, Checkmate 9DW for hepatocellular carcinoma, 2 pancreatic cancer trials, GIANT and RTOG 0848, as well as ending with 4 colorectal cancer studies, Dynamic, Checkmate 8HW, Collision, and Transmet. All right, so I'm going to start with key takeaway points and conclusions. So for the ESOPEC trial, perioperative FLOT in surgery improved overall survival compared to neoadjuvant chemoradiation and surgery for patients with resectable esophageal adenocarcinoma and is now the preferred treatment approach for the majority of these patients. From Checkmate 9DW, Nivo plus IPI may be considered a first-line treatment option for patients with advanced HCC, particularly if these patients are not a candidate for atezo-bev or if a high response rate is needed. From the GIANT trial, EA2126, both dose-attenuated gem-nab-paclitaxel and 5-FU liposomal irinotecan are first-line treatment options in vulnerable older patients with metastatic pancreas cancer. Geriatric assessments and baseline symptoms are probably most important, more so than ECOG performance status in selecting our patient population. From RTOG 0848, the addition of adjuvant chemoradiation to adjuvant chemotherapy did not improve overall survival for patients with resected head of pancreas cancer, but may be beneficial in a selected subgroup of patients with low or no residual disease after chemotherapy, such as those who are node negative. Updates from the Dynamic trial. The role of ctDNA to assess MRD should be incorporated into standard of care for stage 2 colon cancer, but best practices to guide decision-making are not known. From Checkmate 8HW, Nivo plus IPI is a standard of care option in the first-line setting for patients with metastatic microsatellite high colorectal cancer, but it's not the only treatment option. And last but not least, from the Collision trial, ablation appears equivalent to resection for small, ideally located colorectal liver metastases. And from the Transmet trial, liver transplant with chemotherapy carries the potential for extended survival as compared with palliative chemotherapy for unresectable colorectal liver metastases, but identifying the ideal patient remains challenging. All right, so let's start with updates in the management of resectable esophageal adenocarcinoma. So summarized here are the current treatment guidelines for resectable esophageal adenocarcinoma. You can see that for early stage patients, endoscopic mucosal resection and surgery are the treatments of choice. But here we're focused on locally advanced patients, where standard of care is currently either chemoradiation, followed by surgery, followed by nivolumab if there's no pathologic complete response, or perioperative chemotherapy with FLOTs. The choice of treatment currently has really comes down to where the patient and what country the patient lives in. Now, taken from Dr. Goodman's excellent review of this trial, the Dutch cross trial defined the preferred standard of care for neoadjuvant chemoradiation. Patients were randomized to surgery alone versus preoperative chemoradiation. The investigators used a low dose of radiation, 41.4 gray, along with low dose radiosensitizing chemotherapy, specifically weekly carboplatin and paclitaxel for 5 weeks. So despite the low doses of chemotherapy, there was a significant improvement in all survival outcomes with preoperative chemoradiation. The cross regimen was also very well tolerated and did not increase postoperative complications. When we look at the recurrence patterns, chemoradiation reduced the local and regional recurrence rates, but it did not impact the distant relapse rates, likely due to the fact that there was inadequate systemic therapy doses with the weekly carbotaxol. So the German FLOT4 study defined the preferred standard of care for perioperative chemotherapy. It compared the FLOT and MAGIC regimens. The 5-year survival for the FLOT arm was 45%, very similar to the 5-year survival of the chemoradiation patients on the cross trial. This left us with the conundrum of which is the better regimen. The NeoAegis trial was initially designed to compare MAGIC to cross. It was later amended to allow patients to receive FLOT. This study showed an improvement in all markers of local tumor response with preoperative chemoradiation, but this did not translate into an improvement in 3-year overall survival. In addition, there was no significant difference in the severity of complications between the two arms. And as such, the investigators concluded that the data supported clinical equipoise. So this led to the question of, is perioperative chemotherapy superior to neoadjuvant chemoradiotherapy? And the ESOPEC trial was designed to prospectively compare these two approaches head-to-head in patients with resectable esophageal adenocarcinoma. So the ESOPEC trial enrolled 438 patients with clinical T1 node positive or T2 to 4 node negative or positive non-metastatic esophageal adenocarcinoma patients from 25 sites across Germany between 2016 and 2020. Patients were randomized 1-to-1 to perioperative FLOT versus cross, and the primary endpoint was overall survival. Now, this was also taken from Karen Goodman's review. So on the left are the results from the ESOPEC trial. You can see the very impressive improvement in median overall survival of 66 months versus 39 months, and a 7% improvement in 3-year overall survival in the FLOT arm, 57.4% versus 50.7%. She highlighted in her comments that some of the surprising findings, though, when compared to the performance of the cross regimen in previous trials. She noted that only 67% of patients on the cross arm completed preoperative chemoradiation. That was much lower than what was seen on the cross trial, as well as on the NeoAegis trial. The pathologic complete response was also lower on this study, only 10%, when it was 23% on the cross study. And it's hypothesized that perhaps that's related to the timing of surgery following the completion of chemoradiation, which was shorter in the ESOPEC trial than it was in the cross trial. And we all know that the time from the completion of chemoradiation to surgery can impact path CR rates. And then lastly, I want to point out that the median survival for the cross arm in the ESOPEC trial was much lower than on the cross trial or the NeoAegis trial. So as we look closer at the subgroups, there was no group in which cross did better. But interestingly, there was less of a benefit for FLOT for the node negative and T1 to 2 patients, where the systemic risk was likely lower. There was also less of a benefit for FLOT in older patients, possibly because FLOT is less well tolerated. So while perioperative FLOT versus cross has now been settled, I think we can all agree this is a positive study. How can we better tailor treatments for our patients? Because I don't think this is necessarily the end. And that's because we have to take into consideration the results of the Checkmate 577 trial of adjuvant Nivo after preoperative cross and surgery for patients who did not achieve a pathologic complete response. This study showed that adjuvant Nivo significantly decreased metastatic recurrence and it doubled disease-free survival. So based on these results, it's currently standard of care in the United States to give, if you're using the cross regimen, then you give adjuvant nivolumab if a patient does not achieve a pathologic complete response. So since the ESOPEC trial did not give patients adjuvant nivolumab, we cannot conclude that perioperative FLOT is better than preoperative cross in adjuvant nivolumab. So while immunotherapy has an important role in the landscape and the management of esophagogastric cancers, to date, there's no benefit in survival with the combination of chemotherapy and immunotherapy for resectable esophagogastric cancers. And here I highlight Keynote 585, Attraction 5, Matterhorn, and Dante trials. So in summary, perioperative flot in surgery was associated with improved overall survival as compared to preoperative cross regimen, demonstrating the superiority of a more intensive systemic therapy approach for esophageal and GE junction adenocarcinomas. And so as such, flot will likely be adapted as a more standard approach in the US for esophageal and GE junction adenocarcinomas, but the option of cross, then surgery, then adjuvant Nevo, if there is residual pathologic disease, is still a viable option and is quite well tolerated. So moving on to HCC and the landscape for advanced disease. So these are the FDA approved agents in the first line, second line, and third line. We all know that tyrosine kinase inhibition like lenvatinib or sorafenib was initially the mainstay of first-line treatment for more than a decade, with a median overall survival of about 12 to 14 months until the introduction of immunotherapy-based regimens. So in Checkmate 040, Nevo plus Ipi demonstrated meaningful efficacy and manageable safety in patients with advanced HCC who were previously treated with sorafenib. And so this led to accelerated approval in March of 2020 in the United States for this patient population. So what if you bring this regimen, that is Nevo plus Ipi, into the frontline setting? And that led to the Checkmate 9DW study. So this was a global phase 3 randomized open label study design, randomizing patients 1-to-1 to Nevo plus Ipi versus investigator choice tyrosine kinase inhibitor. That was either lenvatinib or sorafenib, and to note 85% of the patients on study received lenvatinib. Patients were systemic therapy naive. They had good child Pew score, ECOG performance status of 0-1, and did not have any main portal vein invasion. The primary endpoint here was overall survival. And the study met its primary endpoints with an improved median overall survival for Nevo plus Ipi of 23.7 versus 20.6 months for a tyrosine kinase inhibitor for a hazard ratio of 0.79. And this is one of the longest median overall survivals we have encountered for this disease. I'd also like to highlight here that there continues to be a survival benefit rate all the way out to 36 months. Since the design of this trial, though, there are 2 new regimens that have been established as first-line standards of care for unresectable HCC. Everyone here, I'm sure, is familiar with the Tezo-Bev, FDA approved based on the IM-Brave 150 trial, which showed a 44% reduction in the risk of progression or death compared with sorafenib, and an overall response rate of 28%. On the bottom, you have durvalumab and tremelimumab, which was compared to sorafenib in the Himalaya trial, which showed a 22% reduced risk for progression or death compared with sorafenib, and an objective response rate of 20.1%. So again, we just saw a 36% objective response rate with Nevo plus Ipi. Other results that were reported in this study, so all subgroups favored Nevo plus Ipi. There was no difference in median progression-free survival between the arms, but there was a numerically higher progression-free survival with Nevo plus Ipi at 18 and 24 months. Again, the response rates for Nevo plus Ipi were really quite impressive, 36% compared to 13% for a TKI, and this included a 7% complete response rate versus 2% for a TKI. This, again, was the highest response rate we've seen in a frontline immunotherapy trial. Those who responded did show response for a long time, more than 30 months. This was more than double what was seen for a TKI. No new treatment-related adverse events. They were what you would expect for each of the drug regimens. And then time to first symptom deterioration was delayed for the Nevo plus Ipi arm, and there was a trend toward improvement in health-related quality of life. So my takeaway here is that Nevo plus Ipi may now be considered a first-line treatment option for patients with advanced HCC, specifically in patients who are not candidates for Atezo and Bev. And as you know, many patients are not candidates for bevacizumab, given this patient population. And then also can be considered in patients who really need a high response rate, whether because they have a high burden of disease and lots of symptoms, or whether it's because you might be able to convert them from unresectable to resectable. So care of the older adult with metastatic pancreas cancer. So although the median age of patients with pancreas cancer is 70, data is limited to drive our approach of older adults with metastatic pancreas cancer. Real-world data shows a significant percentage of older adults remain untreated, with lower survival in those that receive therapy. We know that biweekly gem-nab-paclitaxel is better tolerated than what was originally studied in the day 1, 8, 15 schedule in the MPACT trial, especially in elderly patients. Geriatric factors like comorbidities, function, cognition, psychosocial support, and nutrition directly affect outcomes of older adults with cancer. It's recommended by ASCO and NCCN that patients 65 and older undergo geriatric assessment to assess vulnerabilities. Previous randomized control trials demonstrate the potential integration of geriatric assessments to reduce toxicity. But this was the first trial to do so. This is a randomized phase 2 study of gem-nab-paclitaxel compared with 5-fluorouracil, leucovorin, and liposomal irinotecan in older patients with treatment-naive metastatic pancreatic cancer, the GIANT trial, run by ECOG Akron EA2186. So the GIANT trial enrolled elderly patients over the age of 70. About 60% of the patients were over the age of 75. With untreated metastatic pancreas cancer and with an ECOG performance status of 0 to 2. And the vast majority, 87%, had a performance status of 0 or 1. All patients underwent a novel geriatric screening assessment that focused on 3 domains that was able to categorize these patients as fit, vulnerable, or frail. And about 35% of these patients qualified with over 2 or more domains in terms of vulnerability. And so only vulnerable patients were enrolled, and these patients were then randomized to the control arm, which was modified gem-nab-paclitaxel. So it's full dosing nab-paclitaxel, but given every 2 weeks, day 1 and 15, versus the experimental arm of dose-reduced 5-fluorouracil in combination with liposomal irinotecan. And here, the dose adjustment is that liposomal irinotecan was 50 milligrams per meter squared. Additionally, any patient over the age of 80 was automatically qualified for this study. So patients were followed until disease progression with repeat of modified geriatric assessments and a quality of life evaluation every 8 weeks. And the primary endpoint here was overall survival. So on the left, you can see that there was no statistically significant difference in overall survival between the 2 treatment arms. Both arms did not do very well, with gem-nab-paclitaxel at 4.7 months and 5-FU liposomal irinotecan at 4.4 months. Nearly 30% of patients never started on therapy or only received 1 dose of chemotherapy. And perhaps these patients really may be better off receiving best supportive care. On the right, the investigators looked at overall survival in patients who were able to get more than 4 weeks of treatment. In this cohort, the median overall survival was 8 months. And so that's more in line with what we'd expect for this patient population. So looking at the primary endpoint by stratification factors, one of which was performance status, there was a clear difference between patients who fell into the category of performance status 0 to 1, or those versus those of performance status of 2. Clearly, those with a performance status of 2 did very poorly with treatments. The study also enabled us or gave us a lot of wealth of information about geriatric assessments and quality of life measurements in this patient population. And what you see here on the right is there is a significant correlation between baseline symptoms and outcomes. So really, perhaps early aggressive supportive care may be more important than starting chemotherapy in a subgroup of these patients. So in summary, a similar overall survival and tolerance was seen between dose-attenuated regimens of gem-nab-paclitaxel and 5-FU liposomal irinotecan in this vulnerable patient population. And therefore, both regimens are perfectly acceptable. Perhaps assessing patients and making decisions based on toxicity profile would be very reasonable. It's also really important to note that survival in this vulnerable patient population was lower than expected, with a very high percentage of patients not able to start on treatment or not even complete 1 month of therapy. And so thinking about better tools to assess this older population and perhaps trying to use best supportive care in the subgroup of patients who will not benefit from chemotherapy. The second study we're going to look into in pancreatic cancer is taking a look at a new perspective on the role of adjuvant chemoradiation for pancreas cancer. So the role of adjuvant radiation in resected pancreatic cancer is controversial. Some trials show benefit, some trials show detriment. And the most recent NCCN guidelines from February 2024 state after resection, patients may receive adjuvant radiation for features that portend high risk for local recurrence. As an example, positive resection margins. So this is the NRG Oncology RTOG 0848 trial, looking at adjuvant chemotherapy with or without chemoradiation for patients with resected head of pancreas adenocarcinoma. And these are the results of the radiation plus 5-FU or capecitabine randomization step, which was the phase 3 randomized portion of the study. So again, the primary objective here was to determine if adjuvant chemoradiation following curative intent surgical resection and 6 months of systemic therapy improved overall survival for patients with pancreas cancer, specifically head of pancreas cancer, versus 6 months of adjuvant chemotherapy alone. And this was the study schema. So patients with resected pancreatic head adenocarcinomas were initially registered and randomized, as you can see on the top there, to either gemcitabine alone or gemcitabine with erlotinib. At the time of the study design, which was in 2008, the only effective adjuvant systemic therapy for pancreatic cancer was gemcitabine alone. So arm 2, gemcitabine with erlotinib, closed in April 2014 in response to the LAPO-7 data. And that phase 2 portion of the study was published in 2020. Subsequent to that, so starting in June of 2016, patients were just registered and they went on to either gemcitabine alone or combination chemotherapy for 5 months. It's important to note, though, that despite that modification, no patients received FOLFIRINOX on this study, and only 5% received non-oxaliplatin gemcitabine-based combinations. So then if there was no progression after 5 months, patients went on to the second step, so that's below, circled in red, which was the radiation randomization. So patients either continued with 1 more month of chemotherapy or 1 more month of chemotherapy followed by chemoradiation. Patients were then stratified by nodal status, and about a quarter of patients were node negative. CA19-9 results, and to note, about 96% of patients had a CA19-9 under 90. Surgical margins, the vast majority of patients on this study had an R0 resection and adjuvant systemic treatment that they received. So again, the eligibility here included non-metastatic patients, excellent performance status of 0 to 1. There was a CA19-9 limit of less than or equal to 180. Again, vast majority of patients had under 90. And they all had an R0 or R1 resection specifically for a head of pancreas cancer. An operative report had to be present, indicating that no visible tumor was remaining at the end of the operation. As mentioned, it was a 2-step randomization, so there was a period of upfront adjuvant chemotherapy to confirm no disease progression. In the second randomization, patients received the 6th cycle of the same systemic treatment they previously had received, followed by either no further therapy or chemoradiation. The radiation was 50.4 gray and 28 fractions, combined with either infusional 5-FU or capecitabine concurrently with the radiation. The study did require real-time radiation quality assurance with 3D or IMRT treatment planning. There was also scoring of adherence to protocol specifications and approval of all radiation treatment plans prior to initiating therapy, and that was in response to criticism of prior radiation trials. So a total of 546 patients were accrued onto step 1. Only 65% of them were able to undergo the second randomization, thus selecting for patients who may not have progressed and would more likely benefit from local regional treatment. There was no overall survival improvement for all patients. I did not show that here on this slide, but there was a significant improvement in disease-free survival, which is noted there on the right. The 5-year disease-free survival for the chemotherapy alone arm was 15.2%, which increased to 21.4% for the patients receiving chemoradiation. Even in this very highly selected patient population, though, distant recurrence was still very common, demonstrating the high metastatic potential for this disease. Now, on the left side here is the forest plot of the overall survival treatment effects in the pre-specified subgroups. Interestingly, there is an improvement with the addition of chemoradiation in the node negative group. In other words, patients with low or no residual disease or systemic disease benefited the most from chemoradiation. So we often then send our patients for adjuvant chemoradiation for a positive margin. But again, interestingly, there did not seem to be a survival benefit in that patient population for chemoradiation. This was a very small subset of patients on this study. Remember, it was only 17%. But perhaps margin status is a surrogate of underlying biology or a marker of residual or local disease. On the right, looking a little more closely at our node negative patients, are the survival, which is on the top, and disease-free survival curves on the bottom, showing that there was a significant benefit for chemoradiation. There was a nearly 20% 5-year overall survival benefit for chemoradiation over adjuvant chemotherapy alone, and the median overall survival increased from 3 to 3.9 years. This was even more marked for the disease-free survival, improving 5-year disease-free survival from 19% to 47% with the addition of chemoradiation. So admittedly, this is a confusing study. It's caused a lot of discussion amongst experts who are part of NCCN and radiation guidelines. It'll be interesting to see what comes out in the next iteration. And currently, I would say practices are not changing, but they are in discussion regarding these interesting node negative findings. So in summary, the addition of adjuvant chemoradiation to adjuvant systemic treatment did not improve overall survival for all patients, but it may be beneficial in a selected subgroup of patients with low or no residual disease recurrence, such as those who are node negative. However, I think there are two really key unanswered questions here. One is, how do we interpret these results in the era of different adjuvant chemotherapy? Remember, no patients on this study received adjuvant FOLFIRINOX, our current standard of care. And two, how do we interpret these results in the era of frequent neoadjuvant treatment? So I'm looking forward to seeing the publication of this paper and ongoing discussions of how this may or may not impact practice moving forward. So for the remaining half of my time, we're going to talk about colorectal cancer, starting with the use of MRD-guided strategies in early stage colon cancer. So the optimal management of stage 2 colon cancer continues to be debated. The majority of patients are cured with surgery alone. There is no clear overall survival benefit with adjuvant chemotherapy, even with oxaliplatin doublets in high-risk patients. It's important to note, as you can see here, NCCN guidelines separates out microsatellite stable and microsatellite high patients. And so microsatellite high patients typically do not receive adjuvant chemotherapy. Now, so this really calls for more precise prediction to better inform treatment selection. There are many clinical applications of ctDNA, one of which is the high prognostic impact of ctDNA. So specifically using it in the post-curative intent surgery setting prior to adjuvant chemotherapy. Now, as a reminder, low levels of circulating free DNA can be detected in the plasma of healthy adults. Circulating tumor DNA detects mutations in circulating free DNA that are highly specific for cancer. It has a short half-life, and the quantity of circulating tumor DNA is dependent on the cancer burden. Now, the detection of circulating tumor DNA following curative intent surgery is certainly highly prognostic. We have now seen that repeatedly in multiple studies in colorectal cancer. And here is some data, as representative data from both tumor-informed and tumor-agnostic platforms. And what we now know is that almost all patients with who are ctDNA positive will recur if they are left untreated. But how can we use this as a predictive marker? How can we use ctDNA for an opportunity to de-escalate or escalate standard treatments? And this is where the dynamic study came into play to ask that question. Can we use ctDNA to predict which stage 2 colon cancer patients should receive adjuvant chemotherapy? Now, this is the overall survival and updated 5-year results from the randomized dynamic trial. So as a reminder, dynamic is a non-inferiority study. It evaluated patients with stage 2 colon cancer, ECOG performance status of 0 to 2, who had undergone an R0 resection. These patients were randomized 2-to-1 to ctDNA guided management or standard management following surgery. For the 2/3 of patients randomized to ctDNA guided management, those with a ctDNA positive result at week 4 and or at week 7 received adjuvant chemotherapy, while patients with a negative ctDNA result were observed. In the standard management arm, adjuvant treatment decisions were based on physician discretion by conventional criteria. So the ctDNA analysis in this study was done by a tumor-informed assay with a median of 3 variants, and of note, it's not a commercially available assay. Patients were monitored for recurrence for 5 years, and the primary endpoint, which was already reported, was recurrence-free survival at 2 years. Now, baseline characteristics were pretty well balanced between the arms. I want to highlight that in the circulating tumor DNA guided arm, about 85% of patients had T3 tumors, about 20% had microsatellite high tumors, and about 40% had at least one high-risk feature. Additionally, the primary analysis, again, which was already published in 2022, showed that a ctDNA guided approach significantly reduced adjuvant chemotherapy use compared to standard management. So from 28% down to 15%, and did not compromise 2-year recurrence-free survival. So this is new data. The 5-year recurrence-free survival rate was 88.3% for the ctDNA guided management arm versus 87.2% for the standard management arm. And the investigators confirmed the non-inferiority of ctDNA guided management in stage 2 colon cancer. For patients with T4 tumors, there was a numerically higher 5-year recurrence-free survival of 81.2% for ctDNA guided management compared to 70% for standard management. Notably, the use of chemotherapy was substantially lower for ctDNA guided management at 27.3% compared to 70% for standard management, although the oxaliplatin use was higher in the ctDNA guided arm. However, I don't think the effect is just due to oxaliplatin. For comparison, the 5-year recurrence-free survival in the IDEA collaboration was 73.7% for T4N0 tumors. Again, all of those patients received oxaliplatin. Yet we saw improvements in recurrence-free survival beyond that in this study. So therefore, I think we have to ask what the makeup of all these patients were in this study. We know that 20% of the T4 tumors were MSI high, but we don't yet know the frequency of ctDNA positivity in the standard management arm. That has not yet been analyzed. On the left, 5-year overall survival rates by treatment arm were similar. When overall survival was stratified by ctDNA status on the right, the investigators saw a superior 5-year overall survival rate in untreated ctDNA negative patients at 95.3% versus treated ctDNA positive patients at 85.6% with a hazard ratio of 3.3. Interestingly, the curves don't separate until about 3 years, which may speak to the lead time of ctDNA. So the investigators also collected serial blood in ctDNA positive patients who underwent adjuvant chemotherapy. Overall, the ctDNA clearance rate was 78.6% for single agent chemotherapy versus 92.3% for oxaliplatin-based patients. More importantly, the recurrence rate was substantially lower in patients who achieved ctDNA clearance, 8.6% compared to 80%. And this translates on the right into a 5-year recurrence-free survival of 85.2% with ctDNA clearance compared to 20% for those who are persistently positive. So in summary, assessment of postoperative DNA should be incorporated into standard of care for stage 2 colon cancer, but I still think that best practices to guide decision-making are not yet known. In the dynamic trial, a ctDNA-guided adjuvant approach for stage 2 colon cancer resulted in less chemotherapy, proportionally more oxaliplatin use, and did not compromise long-term outcomes. And so really another big takeaway is that it's critical to achieve ctDNA clearance with adjuvant chemotherapy to have favorable outcomes. Switching gears to the treatment of metastatic MSI-high colorectal cancer. So the current NCCN guidelines do recommend checkpoint inhibitor therapy for patients who have MSI-high colorectal cancer. However, there are a variety of options, including nivolumab with or without ipilimumab, pembrolizumab, or dostarlimab. And there is a footnote there stating that nivo plus ipi is a category 2B when intensive therapy is not recommended due to toxicity concerns. Despite improvement in progression-free survival with pembrolizumab versus chemotherapy as first-line treatment for MSI-high colorectal cancer, as demonstrated in KEYNOTE-177, an unmet need remains. So it begs the question, is an immunotherapy doublet better than a single agent? And is it also better than chemotherapy? And that's where Checkmate 8HW came in. So Checkmate 8HW is a randomized, multi-center, open-label phase 3 trial to evaluate the efficacy of nivolumab alone, nivo plus ipi, and versus chemotherapy. A total of over 800 patients were enrolled in on this study over various lines of treatment, but the data that was just presented at ASCO is only for those who received first-line nivo plus ipi or investigator choice chemotherapy, which was doublet chemotherapy with or without a targeted agent. Of course, the elephant in the room here and what we're all eagerly awaiting is nivo versus nivo plus ipi, but those results have not yet been presented. Eligibility required MSI or MMR testing locally, but about 83 to 85% were confirmed centrally. There was a significant amount of crossover in the chemo arm. 67% of patients subsequently received IO therapy. That one could say that is high. Alternative perspective is that's frankly low, that if you're MSI high and received chemotherapy first line, you would think more patients might have received something second line. So as presented at ASCO GI 2024, so back in January, the study met its primary endpoint, which was progression-free survival with a hazard ratio of 0.21. There was an early and sustained separation of the curves that happened at about 3 months. In this study, only 10 to 20% of patients had primary resistance to nivo plus ipi. If you remember the curve I just showed a few slides back, in KEYNOTE-177, primary resistance was in about 30 to 40% of patients. The 24-month PFS rate was 72% for nivo plus ipi compared to 14% for chemotherapy. And the PFS benefit for nivo plus ipi versus chemo was robust, and it was seen across all subgroups favoring nivo plus ipi, including those patients with liver metastases, BRAF mutations, and Lynch syndrome. Now here you can see the progression-free survival 2, which is defined as the time from randomization to progression on next line therapy or any cause of death. PFS2 was assessed to better understand the impact of subsequent treatment on efficacy outcomes. Some suggest that PFS2 is a reliable surrogate for overall survival, or more of a reliable surrogate for overall survival than PFS. So in the right, the upper part of the slide, is PFS2 from the Checkmate 8HW study. So remember in the chemo arm, I said 67% of patients received subsequent immunotherapy, specifically 46% of them crossing over to the nivo plus ipi arm. The PFS2 here favored nivo plus ipi with a 73% reduction in risk of death or disease progression after first subsequent therapy. And you can see the 24-month PFS2 rate was 83% for nivo plus ipi versus 52% for chemo. So although we don't like to do cross-trial comparisons, I am not doing a cross-trial comparison, but I think it's important here, since all we can do is extrapolate data at this point until we have direct comparisons. I have included the PFS2 data from the KEYNOTE-177 trial, which looked at pembrolizumab versus chemotherapy. So the safety profile of nivo plus ipi was manageable and consistent with the known safety profile of the regimen. Patients who received nivo plus ipi experienced 23% grade 3/4 treatment-related adverse events compared to 48% for chemo. I do want to highlight, though, that there were 2 treatment-related deaths in the nivo plus ipi group. These were for myocarditis and pneumonitis, and none in the chemo arm. Additionally, another patient in the chemo arm who went on to receive nivo, who crossed over to nivo plus ipi, had grade 5 myocarditis as a subsequent treatment-related adverse event. So how do we put all these data together? Here's Checkmate 8HW, KEYNOTE-177, and then I haven't mentioned Checkmate 142. This was presented by the discussant at ASCO. And Checkmate 142 was a phase 2 non-randomized study of nivo plus ipi and separately nivo. And it nicely compares all the responses, PFS and OS, but really what I want to highlight here is that we still don't have all the data. And so I think until we have more of the data, we have multiple options that we can choose from, whether it's single agent or doublet for our patients. So in summary, Nivo plus IPI is a standard of care first-line treatment for patients with metastatic microsatellite high colorectal cancer, but it's still not the only treatment for this patient population. And I think we are all eagerly awaiting the head-to-head comparison of Nivo versus Nivo plus IPI. I think we should also highlight that there are still patients who have primary resistance to these therapies. We need to better understand who those patients are and also develop biomarkers to better personalize therapy, both in terms of response, but also in terms of trying to identify patients at high risk for toxicity. So switching gears to resectable liver-only metastatic colorectal cancer. So what do the guidelines say regarding when it comes to resectability of metastases and local regional therapies for liver metastases and colorectal cancer? So NCCN, ASCO, and ESMO all indicate that surgical resection should be considered as first-line treatment for patients with colorectal liver metastases. They note that thermal ablation should be reserved for tumors that are not amenable to resection. Well, what does the data show for surgical resection? A 5-year survival of about 50% and a cure rate of about 15 to 25% for all comers. And what about the data for thermal ablation? Here is the first randomized study on the efficacy of ablation plus chemotherapy versus chemotherapy alone. On the left, you can see that the study met its primary endpoint on 30-month overall survival. However, the results in the chemo alone arm were kind of in the same range as the ablation plus chemo. But with longer-term follow-up on the right, there was a statistically significant difference in overall survival, favoring the combined modality arm with a hazard ratio of 0.58. In this meta-analysis, there was comparison of surgical resection and ablation. The authors concluded that from a complication perspective, ablation was more favorable compared to surgery, which is kind of not a surprise. If you look at overall survival, though, it favored surgical resection. The problem here, though, is, of course, that it's retrospective. And additionally, there was some bias because patients who received ablation could not have undergone resection. So that then led to this prospective question: is thermal ablation or surgery better for colorectal liver metastases? And the investigator set out to complete that, to find that answer in the Collision trial, which was an international phase 3 randomized trial, although it was predominantly Dutch. It was a relatively straightforward non-inferiority study design. Patients with extrahepatic metastases were not permitted. They had good performance status of 0 to 2 and less than 10 liver metastases. All cases were reviewed by an expert panel of surgeons and interventional radiologists. There were 3 stratified groups: patients with limited disease burden, intermediate burden, or high burden. Patients were randomized 1-to-1 to resection and ablation, and the primary endpoint was overall survival. Now, taking a look at baseline characteristics, so the majority of patients were microsatellite stable. Most patients had low disease burden, which was defined as a maximum of 3 liver metastases and all smaller than 3 centimeters. 64% of the resections in the low disease burden group were done laparoscopically, specifically robot-assisted, and 83% of ablations in the low disease burden group were performed percutaneously. The primary endpoint here was overall survival, and there was no significant difference between surgical resection and thermal ablation, with a median follow-up time of 28.8 months. So in summary here, before I get to the summary, the secondary endpoints were not significantly notable for any change in progression-free survival. There was no difference in local tumor progression-free survival. Again, thermal ablation was at least as good as surgical resection in locally controlling these liver metastases. Thermal ablation was favored when it came to differences in adverse events and length of stay. And then the authors will later report out on quality of life and health economics. So in summary, ablation appears equivalent to resection for small, ideally located colorectal liver metastases. Overall survival was very similar. But the one thing I do want to highlight here is that the median follow-up, as mentioned, was just over 2 years at 28.8 months. And so I think a big question is, well, what will be the survival outcomes at 5 years and 10 years? So thank you for bearing with me for the last, and I know I'm your ticket to lunch. So the very last abstract here is unresectable liver-only metastatic colorectal cancer. So as we just discussed, liver resection is recognized as the best treatment or up to now for colorectal liver metastases to achieve long-term survival and potential cure, but only 20% of patients are initially resectable. For those with marginally unresectable disease, conversion chemotherapy may allow secondary resection after downsizing with a survival benefit. However, for definitively unresectable colorectal liver metastases, chemotherapy is the standard of care for increasing efficacy, but there's almost no chance at long-term survival. The estimated 5-year survival from chemotherapy alone is 5 to 15%. Now, the interest in liver transplant for colorectal cancer was reinvigorated by the SECA-1 trial, which was published in 2013. It had its pros and cons. It's important to note, and a very positive aspect of this trial is that 5-year overall survival was 60%, and this was unlike anything that had been seen to date. Unfortunately, though, the 1-year disease-free survival was 35%, and all patients that were observed for over 11 months had recurrent disease. But what this trial really did do, in addition to those findings, is that it established a set of prognostic factors that were associated with long-term survival that could be carried forward with future trials. Those included size of largest liver metastasis, time from primary tumor resection to liver transplant, elevated CEA, and disease progression at the time of transplant. So about 7 years later, the SECA-2 trial was published. This prospective study of liver transplantation for colorectal liver metastases used a more stringent selection criteria and showed a 5-year survival of 83%. Importantly, about 25% of patients observed for more than 2 years had no evidence of disease recurrence. And so this provided the foundation for the TransMet trial, which compared chemotherapy and liver transplantation versus chemotherapy alone in patients with definitively unresectable colorectal liver metastases. Now, the eligibility here criteria were strict, but I think they were good. These were young patients, good performance status, confirmed unresectability of metastases by expert surgeons. They had undergone gold standard resection of the primary, did not have any extrahepatic disease. They had partial response or stability on chemotherapy for more than 3 months, with up to 3 lines of chemotherapy, no BRAF mutation, low CEA level, and adequate blood counts. Now, here is the study design. Patient selection was made by each center's tumor board and then submitted for validation to an independent multidisciplinary expert committee. Once patients got to that committee, so 157 patients were submitted to the committee, only 94 patients were then randomized, so 60%. So these patients were then randomized 1-to-1 to chemotherapy alone or chemotherapy plus liver transplant. Furthermore, of the 47 patients who were assigned to liver transplant plus chemotherapy, 11 of these patients did not undergo transplant. So I think this really highlights that this was done at sophisticated centers. They had very selective criteria about who to transplant and who not to transplant. Now, at diagnosis, 15% of patients had right-sided tumors. The median number of liver nodules was 20. The maximum size was 5 to 5.5 centimeters. And these patients had a very high clinical risk score of almost 90% in almost 90% of cases. At the time of randomization, the majority of patients were receiving doublet or triplet chemotherapy. Over 90% of patients had received targeted therapy, and 50 to 60% of them had been treated with 2 lines of treatment. So on the left, you can see the intention to treat analysis, 5-year overall survival results, which showed significant improvement in the transplant plus chemo arm compared with chemotherapy alone. And on the right, you can see that this was even more significant with a per protocol analysis. One reason being is that the 2 patients underwent liver transplant in the chemotherapy alone arm, with a 5-year overall survival of 73% in the transplant plus chemo arm versus 9% for chemotherapy alone, with an outstanding hazard ratio of 0.16. So in the chemotherapy alone arm, as you can see, the vast majority of these patients developed progression, switched lines of therapy, and by the end, the vast majority were not NED. In contrast, in the transplant plus chemo arm, 72% of patients developed recurrence, most commonly in the lung. Most of these could be rescued, or about 50% of them, I should say, could have been rescued by surgery or ablation with curative intent treatment. And at the end, 15 patients did not have any evidence of disease, so 42% after a median follow-up of 50 months. But what happens here in the US? So this was published in the Annals of Surgical Oncology in 2023. At the time of publication, 64 patients were identified through the NOS database between 2017 and 2022, and 46 had received a liver transplant in 15 centers. The 3-year overall survival was 60.4%, so not too dissimilar to what's previously been shown. But what I do want to highlight here is the figure on the right. You can see that patients live quite far from the site where they actually get transplanted. And I think this raises an equity question related to who actually is transplanted in this country. So in summary, liver transplant carries the potential for extended survival as compared with palliative chemotherapy for unresectable colorectal liver metastases, but identifying the ideal candidates can be challenging. A couple things that I think are still outstanding is, do we need independent panels to assess eligibility like they did in the TransMet trial? Remember, 40% of patients they deemed ineligible after expert panel review. Maybe do we need to develop standard algorithms to get patients to transplant? Because this is a very heterogeneous patient population. But again, very interesting results. I know we are a transplant center and certainly are evaluating patients on a regular basis for liver transplant in this setting. So thank you for your attention and happy to answer any questions.
On what your is for actually. Because a lot of people have had adjuvant chemo.
So that was, before I answer that question, so that was one of the debated topics with the liver transplant protocol too, because they didn't require adjuvant chemotherapy following liver transplant. The majority did, but the question is it needed? Our practice is if they're newly diagnosed or if they haven't been treated in the past about 12 months, we do tend to give some perioperative chemotherapy, typically about 2 months beforehand. But it's somewhat patient dependent, their comorbidities, toxicity from past treatments, because we typically would do that with a platinum doublet.
We have
Thank you. So the pancreatic into radiation is kind of an interesting thought because, of course, now, as you mentioned, paradigm shifted. I imagine you probably give neoadjuvant to everyone, they candidate for that. But what happens oftentimes, we have a tumor board, and you have people that have neoadjuvant FOLFIRINOX, and then they have either still a lot of residual disease, and everyone says, "Oh boy, maybe we can offer radiation or do something else for them." And then patients that have great response for okay, we're done. But it seems like this kind of flips that paradigm on its head. Maybe we're doing the people that didn't respond are not going to respond to anything, and we're not going to benefit them from radiation. Whereas the people that responded well to chemotherapy are going to be the ones that derive benefit from radiation. I guess I'm just curious what your practice is, kind of incorporating this bit of information that the neoadjuvant setting. And I assume you probably do a lot of neoadjuvant pancreatic.
Yeah, it's a great question, and I eagerly await where this will go and with future trials. We do give a lot of neoadjuvant chemotherapy too, even though guidelines suggest that resectable patients will go to the operating room first, both because of clinical trial opportunities and also because of operating room availability, admittedly. And so these patients receive neoadjuvant therapy. I agree, this data suggests that we are sending patients for chemoradiation. It's really the patients who don't have markers of aggressive biology, who have lower disease burden. So it's the R0 node negative who may benefit from chemoradiation. And I do expect that to be further explored. It hasn't changed our practice. There's been a lot of email back and forth about whether it will or it won't. We haven't sat down with our group yet to discuss, but a lot of my colleagues are on NCCN guideline panels and others, and it's not currently expected to change practice until further data, certainly the paper being published. But I think considering patients with node negative may start to change in some sites, including ours, based on this data. And if for those patients with significant residual disease, node positive, as of right now, there's no data to suggest that further chemotherapy or chemoradiation really does benefit them. So we don't do that.
I guess one other question regarding pancreatic cancer. Do you guys factor in molecular subtype like basal type and consider maybe whether changing your adjuvant, neoadjuvant approach to like a general vaccine or the metastatic setting as well. That's something you guys consider when you're deciding the regimen.
So I think the question of basal versus classical is a really interesting one, and how we can best predict. We know that tumors are mixed, but certainly some tumors favor one over the other, and that is prognostic. It's also predictive of response to treatment. There are ongoing studies in the United States and in Canada evaluating that, including one that we hope to open out in Seattle. As of right now, clinically, we don't use that information to guide our management.
Do you have any other questions?
Thank you so much. For esophagus for the impact study, still sort of struggling in my head though with 67% of people able to complete cross. It just seems like such a shockingly low number, and then with the lack of active movement. Are you guys ready to just wholesale change your standard of care?
So it is a very low percentage, and I don't think they have reported out why that was. And you're right, it did not take into account current standard of care with Nevo as adjuvant therapy. However, our institution is changing practice to perioperative flat as opposed to cross surgery and then Nevo.
Any other questions from the audience?
One brief question. That ctDNA stage 2 colon is very exciting. If I understood your presentation correctly, it has not been approved. It's not a commercial test. It's research-based only. Is that correct?
So there are 2 commercially available ctDNA assays out there. We do use them. Our institution tends to use a tumor-informed assay. There's a tumor-informed and a tumor-agnostic assay. The dynamic trial, the assay they used is not commercially available.
Thank you.
Any other questions from the audience? Thank you so much for coming.
All right, with that, we will go on to our lunch break. It's over at the exhibit hall. There's lunch boxes ready to go for anybody who's staying. And then after that, we'll have our hematology topic coming up. So we'll see you at 1.